us today. Thank you for joining us today for our first of many NY Cannabis Grand Rounds. My name is Sang Choi. I am a research scientist with the Office of Cannabis Management. My professional background is in pharmacy, and I have spent the last 9 years working as a dispensary director for a medical cannabis company in New York State prior to joining the OCM. My passion is educating the public and clinicians alike about the therapeutic benefits, potential applications, and the latest research findings to help advance understanding the medical use of cannabis. So, in that vein, I am pleased to welcome Dr. Maurice Hinson today in honor of Heart Health Month for a presentation on the clinical considerations in the use of cannabis for the prevention and management of atherosclerotic cardiovascular disease. So I just want to give you a little background on Dr. Hinson. He is the CEO of Quantum Wellcare, founding director of MediRoots, and the hospitalist at Jamaica Medical Center. Dr. Hinson received his bachelor's degree in neuroscience from Johns Hopkins University, his medical degree from Drexel University College of Medicine, and completed his residency in internal medicine at New York Presbyterian Weill Cornell. He is also a founder and advisor of the Black and Latino Men in Medicine, which is a network of students, trainees, faculty, and hospital administrators created to combat the precipitous decline of Black and Hispanic male physicians. He is a recipient of numerous basic science research awards, such as the 2015 Excellence in Public Health Award by the U.S. Public Health Task Force, 2020 Drexel University 40 Under 40, and a fellow in the New York Academy of Medicine. His most recent academic interests involve the clinical application of cannabis and psychedelics for the prevention and management of chronic disorders like obesity, heart disease, high blood pressure, diabetes, depression, anxiety, substance use disorders, dementia, and cancer. So please join me in welcoming Dr. Hinson today.
Thank you so much. It's it's an absolute pleasure, it's an honor, especially considering that I still recall my teenage years, like many of you, when I was first introduced to cannabis and I would, play ball with our friends, and then we would go hang out on somebody's stoop and pull our money together and buy a little nick bag of Reggie. At that time, it was Reggie. I didn't know about all these different strains, the Gorilla Glue and Jack Frost and all these things. It was three types. It was Reggie, what you got when you were broke, you didn't have any money. It was um, Diesel, and it was Perp. Perp is what you got when you really wanted that gas, and that was always beyond what I could afford. But you know, going through that and having to hide the fact that I consumed it, even though, my parents, uh, they engaged in their own recreational habits. And then, I had a handful of friends who did time for possession, and one of my closest best friends growing up actually was killed, was murdered, hustling. So the fact that I can stand here now as a physician and speak to the state of New York in its Office of Cannabis Management in front of my peers and colleagues and patients and enthusiasts. It's just an awesome experience. And then this being, the inaugural meeting, the inaugural session, another moment in history during Black history of all times. Because I'm not just a physician, I'm also beautifully chocolate, as you can see. And it means a lot when you consider the atrocities committed against Black people on the so-called war on drugs and the impact that had. But we all know, or at least should know, that was a war against justice. That was a war against civility, against humanity, and certainly a war against medicine. But very proud, very honored to be here, and it's my esteemed honor to represent them. And so, very, very much looking forward to the conversation. My part is only the first part, delivering the information, but I'm really interested to see how people feel about it, the critiques. I'm always open to critiques, to challenges. I think we should do that for intellectual purposes to advance the science of cannabis medicine. And so I'm here for it. Can I go ahead and share my slides? Is that all right? Okay. All right. So again, this is the clinical considerations for cannabis use in the prevention and management of atherosclerotic cardiovascular disease. I have no financial conflicts of interest to disclose. All the opinions and views are mine and solely mine. They don't represent any organization or institution that I'm affiliated with. I'm not selling you any products. The only thing I'm selling you is good science. But with that, like I said, I have no financial conflicts of interest. You already heard my background, so I won't go over this. My aims are to first inform current and future cannabis providers about the potential uses of cannabis for the prevention and management of cardiovascular disease. All right. You'll see that some of the information is very science heavy. So if you don't come from a science background, it may or may not go over your head somewhat, but I'll do my absolute best to make it digestible, to make it palatable. But I'm really trying to address my colleagues and my peers because I think we should lead the charge when it comes to educating the public about the medicinal uses of cannabis. I'm going to challenge our general approach to the medical management of cardiovascular disease somewhat, not opposed, but challenged because I think we're misguided in many of our targets. I'm also going to challenge this negative perception that's been created about cannabis use in cardiovascular disease. I think it's important, it's absolutely important, it's critical actually, to acknowledge and become aware of the risks involved with anything that we do, any medication, any procedure that we perform. But we have to get back to understanding the duality of all things. Nothing is all bad and nothing is all good. And really what it is evaluating the risk benefits associated with its use, given each individual case. And then most important is just to inspire thought and conversation, intellectual debate. So as long as it helps to advance the understanding, the science and practice of cannabis. In terms of my objectives for the audience, or what I hope for you to gather is to discuss the endocannabinoid system and its relationship in cardiovascular function, to briefly highlight the current perception of cannabis use in cardiovascular disease, to discuss the unique properties of cannabis, provide a methodical approach to understanding the unique properties of cannabis and their influence in cardiac function, to provide a framework for addressing the root cause of cardiovascular disease, and finally, to present a practical clinical approach to managing cardiovascular disease and incorporating cannabis. But first, I'm going to start off asking a few questions, rhetorical questions. One, for those of you who are in the science field, I'm curious what score you received on your endocannabinoid system test in school. For me, I wasn't tested at all. And for many of us, it's similar. You know, medical school doesn't incorporate learning the endocannabinoid system in its curriculum. When you think of cannabis, do you only think of THC and CBD? Have you heard of the entourage effect? And if so, do you believe this to be true or a myth? And are you comfortable recommending cannabis to your cardiac patient or your patient who's at risk? And what's shaping that perception? What messaging, what content is shaping your perception around cannabis use in the cardiac patient? For me, I got interested in this topic when I was actually on my way to work and I started seeing these reports coming out in the media showing the risk of cardiovascular disease with cannabis use. And for me, like I have such a profound love for cannabis, I was almost offended when I saw this. It was almost like, when people talk about your mom and your dad, like you're revved up, like you want to fight, like on the spot. And that's how I felt when I started reading these stories. But then, I had to put my personal opinion to the side and get more objective about it and more scientific about it. Because again, not everything is all good, not everything is all bad. So I was curious to see why or what they meant by marijuana use, cannabis use being associated with heart attacks and strokes. But just to take a step back, let's discuss the real issue at hand, which is the disease itself, heart disease, which is the number one leading cause of death in this country. It has a massive economic impact. There are racial disparities that exist. Black people, Black women, and Black men tend to have the highest prevalence of heart disease and die at disproportionately higher rates. We also see a growth of the marijuana industry, the cannabis industry. And this is telling. This is showing you that this is something that people want. And because we're going to continue seeing this growth, it's absolutely imperative that we understand how it impacts our health, and in particular, our cardiac health. And this is why I was so perplexed by the studies, because when you speak to people about why they consume cannabis, and people who come to me for their medical cannabis certification, oftentimes they're dealing with anxiety, they're dealing with depression, they need help sleeping, they need help with pain, to improve their mood. And it just doesn't make sense that we have all these good things about cannabis, but then somehow it harms our heart. And it was something that I just couldn't sit with. But again, I had to remain objective. I had to dig deeper and really try to understand what they meant by this association. But first, let's discuss what's the difference between a medicine and a poison, right? Because that's effectively what we're talking about. And on one hand, they're saying cannabis is bad for your heart, but on the other hand, look how many people benefit from it. So what's the difference between a medicine and a poison? When you consider snake venom, is this a poison or is it medicine? I think most people would say that it's a poison because we all know the impact of getting bit by a snake. You can, go into anaphylaxis, you can lose a limb, you can die from it, right? But if you took that same venom and you diluted it, it was actually one of the original anti-platelet therapies and one of the original hypertensive therapies. And so what appeared to be a poison at high dose is actually a medicine at lower doses. How about water? I don't think anybody would consider water to be a poison, right? But if I asked you to drink a gallon of water, which is about close to 4 liters, like 3.8 liters, if I asked you to drink that gallon of water in 2 hours, you could probably do it. You might be a little uncomfortable. Your belly might be a little bloated, but you could do it and you won't have any real ramifications from it. But if I gave you that same gallon of free water by way of IV, then we might start seeing some serious electrolyte derangements, some fluid shifts, changes in mental status, possibly even death. So here it seems like the same substrate, water, if delivered in a different route of administration, could be potentially lethal. So it appears that the only difference between a medicine and a poison is the outcome, right? If the outcome is good, then it's a medicine. The outcome is bad, it's a poison. And usually what determines that outcome is the route of administration and dosage. Now, I believe that applies to cannabis as well, but we'll go deeper into that. So the study that everyone was reporting at that time was the one that came out in the Journal of American Heart Association, where they said cannabis use is associated with adverse cardiovascular outcomes. And this cooperated with many other studies previously published. This is a meta-analysis looking at a bunch of different studies, looking at it. And overall, it showed a significant association between cannabis use and cardiovascular risk. But when you look deeper into this study, when you sift through all the materials and methods and how they stratify patients, and when they surveyed the patients, what they discovered was that 74% of the participants reported smoking cannabis as their primary method of consumption. Now, why do I bring that up? Well, smoking anything increases your risk for cardiac disease. And that's because the generation of free radicals and reactive oxygen species are highly pro-inflammatory. Plant material combustion causes the release of volatile organic compounds and other inflammatory and potentially carcinogenic compounds. You get the generation of carbon monoxide, and carbon monoxide causes oxygen to bind more firmly to hemoglobin. So then when that hemoglobin is trying to deliver oxygen to the tissues that need it, it can't do so. So you get decreased oxygen delivery to tissues in need. When you decrease oxygen to the point where it does not match the necessities of that tissue, that's when you get what's called ischemia. All right, you get poor blood flow, poor oxygen delivery, you get ischemia and tissue injury. When that occurs in the coronary arteries, that is the definition of a heart attack. All right, myocardial infarctions is ischemia within the coronary arteries. All right, so it appears smoking anything increases your risk for developing cardiac disease. And there have been some other mechanisms that have been linked to cannabis use in cardiovascular disease. One being this arteritis, this vasculitis, that seems associated with heavy metal, arsenic. All right, it's a vasculitis and it causes inflammation of the arteries. There's coronary vasospasm, so that's when the vasculature constricts and decreases blood flow. In some reports, we see increased platelet aggregation. All right, platelets are crucial cells in the formation of plaques. All right, the thrombus that forms and blocks the arteries. We see increase in inflammation. All right, and we also see increased sympathetic activation. And we'll go into this more. Okay, I know I'm throwing things out there before I've actually described what THC and CB1 and all these things are, but this just shows you that this has been studied, all right, and it does cooperate with what this most recent article was suggesting. But then when you look at other studies that have been done, studies that have been published in the literature, there are plenty that show no association between cannabis use and cardiovascular disease. And the two that I placed here, I did so because these are relatively larger studies, so they're powered pretty well. And they found no association. All right, so on one end, we have this really good study that was published in the Journal of American Health Association, because it was a very good study. But we have other really good studies that show the opposite, or at least show no effect, or no association rather. I included this one because everything that I've described so far relied on retrospective analysis, so surveys, and they oftentimes allow for a lot of bias, recall bias, selection bias, all these types of biases that may skew the data. But this I selected because it's a genetic study, right? We're looking at small nuclear polymorphisms that are associated with cannabis use and determining whether there was any association of those with cardiovascular disease. All right, so either the SNP exists or it doesn't. All right, and what we found that there was no association. All right, no significant causal association, because it's one thing to be associated, there's another thing to cause it. All right, so for the consumption of cannabis use to cause cardiovascular disease, and this particular study did not show that. So why the inconsistency in this data? Why the inconsistency in cardiac risk with cannabis use? And the primary reason is because of our failure as researchers, and it's not entirely our fault because we can only play with the cards that we're dealt with, right? Cannabis is still a Schedule 1 substance, and so it makes it very difficult to study. All right, so we have to do retrospective analyses, which are not the best studies, but we do what we can. But because it's Schedule 1, we're unable to do the randomized, controlled, double-blind human studies. All right, we need, preferably for it to be, for cannabis to be descheduled, but at the very least, rescheduled so that we can start studying it and using it for medicine. Now I just want to get into the generals, the endocannabinoid system, all right, which is an intrinsic system, is a major regulatory system, if not the biggest regulatory system. All right, it impacts virtually every process, every organ system within our bodies. On the right, I just highlights the many functions of the endocannabinoid system within the body. And with respect to its involvement in the heart, I mean, we have everything from it modulating heart rate, blood pressure, atherosclerotic development, reactive oxygen species generation. So it does a tremendous amount in the heart. Phytocannabinoids act similarly to our endogenous cannabinoids. So our endogenous cannabinoids include things like AEA and 2-AG. The phytocannabinoids are THC, CBD, CBG, CBN, all the things that you've heard. And it has, again, a myriad of different functions by way of these two receptors and by way of other receptors as well. Now, one of many unique aspects about cannabis consumption is the fact that there's so many different routes of administration. I don't know any other medicine that we smoke, right? Some people swear by smoking cannabis and it helps them tremendously. So if it helps, then it's a medicine, right? But you can smoke the flower, you can vapor concentrate. There are edibles that you can take. You can ingest it. You put it sublingually. You could do topicals. You could do suppositories, and so there are a myriad of different routes of administration. This is showing the various cannabinoids and the various phytocannabinoids and their maturation and conversion. So CBGA is considered the mother of all phytocannabinoids, okay? And through enzymatic conversions, it goes to THCA, CBDA, and then by way of heat, we get decarboxylation of THCA, CBDA into THC and CBD, respectively. And each of these cannabinoids has its own mechanism of action, its own effects, and they act like entirely different compounds, even though they derive from the same precursor. All right. And there are hundreds of phytocannabinoids. Okay. Well, I'm only naming a few here for the sake of space, but there are hundreds. Okay? I just mentioned the decarboxylation process, where you go from the acidic form, the natural form, or the native form, I should say, to a neutral form. All right. And what this table shows are the temperatures at which these cannabinoids decarboxylate. All right. So at about 95 degrees Celsius, it takes 50 minutes to result in complete decarboxylation of THCA into THC. Okay. THCA has little to no ability to bind to CB1 the way that THC does. When THC binds to the CB1 receptor, that's what gives you that psychoactive effect, that the high that we all know about. Okay, but THCA does not induce that same effect. Neither does CBD, CBDA, CBGA. CBG is really just THC that has that profound psychoactive effect. Okay. And this is just a schematic showing all the different receptors that the phytocannabinoids target. All right, it's not just about CB1 and CB2. There are a myriad of receptors, and I won't go through them all, but this just shows you just how powerful these compounds are because they have such a large bandwidth, such a large effect on the body. Cannabis is not just about the phytocannabinoids, all right? We have the terpenes. The terpenes are what give each strain its unique flavor and smell. The terpenes have been found to have their own therapeutic potential. All right. And it doesn't just leave at the terpenes, the flavonoids. Okay. Flavonoids oftentimes give it this visible color and the aesthetics of it. But even the flavonoids have their own therapeutic potential. And so you have hundreds of cannabinoids, you've got thousands of terpenes, and you've got a few dozen flavonoids. So you can understand how we can get such a large array of potential variations. I mean, in the billions of different variations. Okay, so this is the beauty and curse of cannabis, because it we have so many different options. We oftentimes we don't know what to recommend to patients. There's no standard cannabis. Okay, this is just talking about processing in a way, right? So we always talk about THC and CBD as if they exist in isolation, but no, they exist in a myriad of other cannabinoids within that plant. All right. So when we take extracts, when we do concentrates, and we take extracts, for example, those extracts can be full spectrum, meaning it contains everything that was in that plant. We get to do broad spectrum, where we take everything that's in that plant and remove the THC, or we could do isolates, okay, like a THC isolate or a CBD isolate, all right? So again, another element of variation. And then its response is very intriguing, right? You can have at low dose it do one thing, at a higher dose do something completely different. Here we're talking about CBD, and when it targets the 5-HT1A receptor, which is part of the serotonergic pathway, we get one effect. It helps to reduce anxiety. But when it targets the TRPV1 receptor, it doesn't have that same anti-anxiety effect. All right. So in many instances, when we deliver these isolates, we find that at certain doses nothing happens, but then at higher doses or lower doses, we get the effect of interest, and that makes it difficult to study. This is where studying the dosing becomes critically important. Then we have this, what was known as the hormetic and homeopathic response. So hormesis is basically what happens at high doses, the toxicity that happens at high doses. You get the exact opposite at low doses. All right, so there appears to be this hormetic zone that they say, this therapeutic zone. All right, so it's not just a matter of it being biphasic, either the effect exists or it doesn't, but actually having an opposite effect. All right, and we see this in this study here on the right. They took two different types of mice. One group of mice, they knocked out the CB1 receptor and the GABAergic interneurons. And in the other group of mice, they knocked out the CB1 receptor and the glutamatergic neurons. Okay. And they found that at high doses, we got decrease in what they call open arms. So just imagine open arms, you're going for a hug, it's all love, everything's all good, you're relaxed. Open arm in mice is an indication of relaxation. All right. So we want more open arms. We want more hugs. We want more love. All right. So at high doses, we see a decrease in the love. All right. We see a decrease in the open arm. So at high doses, these mice are quite anxious. And they discovered that that occurs through the GABAergic CB1 receptor. Whereas when when we stimulate the CB1 receptor at low doses, we increase open arms. As far as much more love, these mice are happy, they're less anxious, they're relaxing. All right, and we discovered that that's through the glutamatergic pathway. All right, so again, at low doses we have one effect, and at high doses we have the exact opposite effect. All right, that's a major principle of hormesis and homeopathy. Homeopathy, one of the big principles is like cures like. So if at high doses it makes me more anxious, a lower homeopathic dose will actually help to reduce anxiety. Okay, so very, very interesting functionality there. Then we have these paradoxical effects, right? Again, I'm hammering this point home for a reason. It should make sense in a little bit. So on the left here, we have two groups, consumer, and by consumer, they mean people who consume cannabis. All right. They didn't delineate how, smoking or oral, topical, whatever, but just they have a history of consuming cannabis. And then they stimulated their platelets. They drew blood from them. Well, I'll take this back. They gave them 20 milligrams of THC, okay, and then stimulated platelet aggregation, platelet activation with collagen. All right, collagen is a known inducer of platelet aggregation. And then they remove the cells from, they remove blood and remove the platelets from those participants. And then they measured the percentage of aggregation. And what they found is that people who consume cannabis has significantly less platelet aggregation. Now, why is that important? Well, when platelets aggregate, they help to form thrombi. Those thrombi are what forms those plaques in your arteries that cause heart attacks. All right, so we don't want platelet aggregation, not out of control. It is a good thing in small doses, but when it happens too often, like in the development of atherosclerotic disease and coronary artery disease, then it's problematic. And so what this is showing is that people who consume cannabis had lower platelet aggregation, which is a good thing, right? However, in the study on the right, it showed the exact opposite. Study on the right shows a dose response increase to THC in platelet aggregation. All right. And so what this is showing is as we increase the dose of THC, we increase the tendency to aggregate platelets and to cause thrombus formation. Right. So these paradoxical effects is what makes this so unique and so interesting, but so challenging to use. Okay. Now I want to highlight how we should be thinking this, how we should group, because there's a lot of information, there's a lot of cannabinoids, there's a lot of terpenes, flavonoids, there's different cultivation methods, there's different processing methods, there's different ways to consume it, different doses. So how do you keep all that together and make sense of it? Well, I'm gonna break it down in this fashion because it's what makes most sense to me and usually how I go about selecting which products to use. So we're getting away from the whole sativa and indica because from a physiologic standpoint, that doesn't mean too much, right? These are phenotypic expressions when you talk about um, um, sativa and indica. But we're getting into the language of chemotypes, all right? And we have essentially 5 chemotypes for now. I'm sure that this is going to grow as we learn more. But chemotype 1 is THC dominant. Chemotype 2 is about a 1-to-1 ratio of THC to CBD. Type 3 is CBD dominant. Type 4 is CBG dominant. And type 5 are absent of cannabinoids entirely. All right. So that's chemotypes. Then you have processing, right? I talked about decarboxylation. So in its raw natural form, the cannabinoids are acidic. Okay. When you heat it at the appropriate temperature for the appropriate duration, they decarboxylate and they become neutral, right? You can further process it by turning them into concentrates, turning that flower into concentrates. And there's a myriad of concentrates. I put them here at the bottom. I'm not going to go over them. But I do want to distinguish them by full spectrum, broad spectrum, and isolates. I described this earlier, okay? Because these do have physiologic importance, and you'll hear about that shortly, okay? Route of administration is critically important, right? Inhalation is very different from oral ingestion. The pharmacokinetic profile is very different, all right? Sublingual, topical, suppository, it's very different, okay? And we've already seen evidence about how dosing changes the effect, all right? So do we want an ultra low dose, normal, high? I don't know. I mean, it really depends, okay? This is the beauty of this plant, but it's also the challenge. So let's contextualize this for a second, right? As it relates to the pathogenesis of atherosclerotic disease. All right. Atherosclerosis is an inflammatory disease, all right, characterized by intravascular plaque formation, which is a composition of fats and inflammatory cells and cellular debris and fibrin and calcium. All right. So for my providers out there, this is why we're doing CT coronaries and calculating a calcium score, because calcium is a mature plaque, right? Risk factors include the metabolic syndrome, so obesity, hypertension, diabetes, high cholesterol, okay, inactivity, smoking, right? And we were learning that plaque formation is accelerated by heightened sympathetic activity or sympathetic overactivity, okay? And so when we describe the metabolic syndrome, and I'm gonna go step by step here, so irrespective of the disease that we're talking about, it seems to be driven by the same things, right? When we look across the spectrum of metabolic syndromes, they seem to have insulin resistance in common, and they seem to have inflammation in common. Most chronic disorders are the result of chronic inflammation. And we're learning more and more how insulin resistance plays a part in the pathogenesis of these disease states also. And we know that smoking not only causes inflammation, which I'm sure we all already understand, but smoking also induces insulin resistance, so it worsens those situations. All right. And so knowing that insulin resistance and inflammation seem to be at the root of these disease states, then it seems to make sense that we should be targeting insulin resistance and inflammation in order to prevent and treat these diseases. But that's not what we do in our healthcare system, unfortunately. And this is where I'm going to challenge it a little bit, right? Because I think our therapeutic approaches to most disease states is a bit misguided, right? Because we are very symptom driven. Everything we do according to the symptom, right? We diagnose by symptoms and we treat the symptom. But treating the symptom is not treating the underlying disease, right? Now, if I use type 2 diabetes as an example of my point, we diagnose it by fasting blood sugar less than or greater than 126 or A1C greater than 6.5, right? These are markers of blood glucose levels, okay? And then our target is to achieve an A1C less than 7, however we can do it, right? So we're targeting blood glucose. But again, I just mentioned that type 2 diabetes is a disease of insulin resistance, not elevated blood sugar. The elevated blood sugar is a symptom of the disease, not the cause of it, right? So when you take that approach, then you'll understand that, well, our methodology in treating diabetes is highly ineffective. And we see this. It's how we treat people with diabetes for life. It becomes a progressive disease. But we're learning that diabetes doesn't have to be a progressive disease. Perhaps we make it worse by the way that we approach it, right? And we learned this in the Accord study. All right. The Accord study was a massive study where they looked at two groups of people, standard therapy. By standard therapy, it means lifestyle modification. And then an intensive therapy group where they added in the sulfonylureas, they added in the PPAR gamma agonists like the glitazones, rosiglitazone, right? Or insulin in order to achieve their target A1C of less than 7, right? And they were able to do so. So they were able to effectively achieve their target A1C of less than 7. But what they found was in doing so, it actually significantly increased the risk of death. All right. So where we were able to achieve our target, and if we were able to achieve our target, then we should see good health outcomes. But no, we saw the exact opposite. And that's because we aimed at the wrong target. The target is not blood glucose. The target is insulin resistance, right? And so I want us to think about that as we go through atherosclerotic disease. right? Let's not treat symptoms. You have chest pain. I don't want to treat your chest pain. I want to treat the underlying reason for the chest pain, right? I'm sure you can go in and you can blast away the coronary arteries, but I want to address the underlying reason as to why you were developing those atherosclerotic plaques to begin with. And again, when you boil it down, you see that it's really three things that drive the development of atherosclerosis: insulin resistance, inflammation, and sympathetic overactivity. All right. And I want to use these three root causes and discuss how cannabis can be used to address these root causes. I pretty much just explained that. So let's look at some cardiac related properties of the cannabinoids. All right, their isolated form. All right, let's start there. It's easier to look at it in that fashion. THC. So for one, it appears that THC increases heart rate in a dose-dependent manner. All right, and we see this pretty consistently. On the right here are human subjects that were given different doses of THC, and then they measured their heart rates. And after about 60 minutes, you start seeing noticeable differences in that the higher dose had a significantly higher heart rate. All right, so it seems to be a dose-dependent increase in heart rate when you administer THC. The blood pressure is mixed. Some studies show that THC administration increases blood pressure. Some say it decreases it. There's discrepancy over whether that occurs in the acute phase or in chronic users. So it's mixed. All right, it's conditional. It depends. Insulin sensitivity across the board. It appears that insulin or cannabis THC improves insulin sensitivity and increases insulin production. Okay, with respect to its role in cortisol production. So cortisol is a hormone, a stress-related hormone. When you're stressed and you activate your sympathetic system, your body produces cortisol, your brain produces cortisol. All right, and cortisol has a myriad of different actions also, but some of which include increasing blood sugar levels by way of causing the liver to produce new sugar called gluconeogenesis. It causes vasoconstriction and therefore elevated blood pressure. Um, it's an immunosuppressant. When that happens for too long, it increases your risk for infections, bacterial infections, viral, fungal. And then there's a certain point where chronic steroid exposure actually flips the switch and becomes pro-inflammatory. So we don't want cortisol around for too long. All right. We do want it, we like it because it gets us going. If we're in fight or flight mode, we have to defend ourselves. We want that cortisol, right? But we don't want it all the time. Too much of anything is not good. And then with respect to inflammation, that's also mixed. It depends. Depends on dosing, it depends on all these things. And this is a perfect example. So in this particular study, they use a mouse model and gave a high dose, what one would consider a high dose of THC daily for 6 weeks. It was actually 1 mg per kg, one milligram per kilogram, intraperitoneally, so in the abdominal cavity. All right. Then they sacrificed the mice, did slides, and they found that the administration of Delta 9 THC at 1 mg per kg intraperitoneally caused significant increases in plaque formation. All right. And this is the vehicle on the side. This medication here is actually is an inhibitor, CB1 inhibitor. Okay. However, in this study, also a mouse model, they gave 1 mg per kg orally. They fed them. All right, same dose, but this one they fed them orally. The other one they delivered by injection intraperitoneally. What they found was a significant decrease in atherosclerotic plaque formation. Right, I mentioned this before. This biphasic effect, this hormetic and homeopathic effect. We're seeing it in real time, you know. And so it appears that the poison is in the dose, right? I left this down here for a reason. It appears that the poison is in the dose. At low dose, THC seems to be of benefit in preventing plaque formation, but at higher doses, it increases plaque formation. And then there was a very interesting study that was done recently, not too long ago, where they did an ultra low dose, all right, 0.002 milligrams per kilogram. Remember, I said the last two examples were 1 milligram per kg. This is 0.002 milligrams per kg, and they delivered this intraperitoneally, and they found that at that dose, there was significant decrease in infarct size, inflammation, and an improvement in heart function compared to the placebo. All right, so it appears that at low doses and ultra low doses, THC helps to prevent atherosclerotic development, but at high doses, it promotes it. All right, very interesting. This is a study showing that chronic cannabis users show blunted stress responses. So here we're giving various doses. On the left side, study one, we're giving 2 doses of THC, delta-9 THC, by way of IV. All right, so this is 0.0357 mg per kg and 0.0714 mg per kg. And what we find, just look at the control subjects who are in blue, that as you increase the dose, you increase the cortisol level. All right, the y-axis is the cortisol, the x-axis is the treatment dose. Okay, when you give higher doses of delta-9 THC, you see increased cortisol production. So there's a direct correlation between THC dose and cortisol in patients who do not consume cannabis. But in the frequent users, these are people who frequently consume cannabis. And I believe in this study was at least 4 times within the past week or 2 weeks. I forget exactly. But what they show is blunting of the cortisol expression. So if you consume cannabis often, you don't respond the same to the stress, to the THC, all right? Which may or may not be good. Here's another study which sort of corroborates the same finding, except in this one, they actually stressed the human subjects, right? So at baseline, no stress, they found that cannabis users at baseline had a slightly higher cortisol level than non-users. Makes sense, right? But when they stressed these human subjects, it was a mental stress test, they found that the cannabis users had a lower cortisol level compared to the non-users. So it appears that in a stress-related event, cannabis helps to suppress cortisol level. And we see that, right? We see that. We know people who smoke all the time. We know our potheads, and they just chill about everything. It doesn't matter. You can let a lion loose in the room. They're just gonna sit there and chill. Like they're not gonna have that same visceral response. Is that a good thing? It's debatable. I don't know. But what this does highlight is the importance of chronicity. So now we're talking about the difference between acute cannabis use and chronic cannabis use. These are 2 very different things also, okay? So another level of complexity. I think you're starting to pick up what I'm putting down. Like, this is a very complex plant medicine that we're dealing with, but that's what makes it so intriguing. Let's talk about CBD, okay? In terms of the heart rate, there's mixed results about that. Some studies show significant increases at baseline when you give healthy control subjects CBD. Across the board, we see that it decreases blood pressure, which is what you want, okay? It improves insulin sensitivity and secretion, just like THC. It lowers cortisol levels. And out of all the cannabinoids that I've studied, and CBD is one of the more studied cannabinoids, it seems to have the most profound anti-inflammatory effects. Okay, and it does this through a myriad of different receptors. Here's just a schematic showing the various mechanisms of action and how it reduces the stress response, or reduces cortisol, reduces inflammation. Okay, this is a study that shows how CBD alters smooth cell aggregation. So these are human coronary smooth muscle cells, okay? And what they did was they exposed these cells, they grew these cells either in normal growth media or with CBD at these various concentrations, right? And then they exposed those cells to PDGF, which is platelet-derived growth factor. Platelet-derived growth factor causes activation and migration of the smooth muscle cells. And what they found is that in the presence of CBD, there was significantly decreased smooth muscle cell activation and migration, even after administering the PDGF. All right. So that's a good thing. All right. Because the smooth muscle cells also play a role in thrombus formation. All right. So it appears CBD helps to prevent thrombus formation by way of decreased migration of these smooth muscle cells. CBG, all right, the mother of all cannabinoids, all right. What's interesting about this, I haven't seen any reports where it alters patients' heart rates, which is great, right? So when you're at risk for a heart attack or you've had a heart attack, you don't want a high heart rate, right? Because it makes the heart work harder. You don't want the heart to work harder. All right, so there was no change in heart rate, and it lowered the blood pressure in a dose-dependent manner. This is great. This is fantastic, right? We have a cannabinoid that doesn't seem to stress the heart at all, right? It improves insulin sensitivity, but unlike CBD and THC, it actually decreases insulin production, all right? And it does this by way of activation of the alpha-2 adrenal receptor, okay? Adrenal receptor, however you say that. I'm a physician, not a linguist, but it's something like that. Adrenal receptor, okay? And it's a potent anti-inflammatory cannabinoid. All right, it decreases platelet aggregation. On the right, I just gave two studies that showed how it decreased blood pressure in a dose-dependent manner. Okay, so CBG seems to be a powerful potential cardioprotective cannabinoid. Right. These are the acidic cannabinoids. Remember, in their native form, they're acidic. And then when we decarboxylate them with heat, they become neutral. Well, it appears that THCA, the native form of THC, the acidic form of THC, causes significant weight loss in an obese mouse model, okay? And it does so by way of increasing insulin sensitivity and by reducing inflammation. And in this particular study, where they did it in mice, so they used a obese mouse model and then gave them THCA, they found that in the obese mice, it caused decreased weight, decreased inflammation, decreased fatty liver, and increased thermogenesis, so brown fat. So it was able to convert white adipose fat tissue into brown adipose fat tissue, which helps you to expend more energy and therefore lose weight. But what's interesting is that in the lean mice, it didn't cause significant weight loss. It helped to improve energy expenditure, but without significant weight loss. So if you're good, if you're already lean in shape, the THCA, it doesn't really bother you. But if you have an issue, if you have excess weight, it helps to reduce that weight. So it almost appears that these cannabinoids are conscious. They know, okay, well, you're good, so I'm gonna leave you alone, but over here you need a little bit of help, so I'll help you. That's what a regulator does. That's what reestablishing homeostasis means. It only acts if it's imbalanced, and that's what we want. CBDA appears to be 100 to 1,000 times more potent than CBD at their respective receptors, or at least, let me take that back, at least with respect to the 5-HT1A receptor, the serotonergic pathway, which plays into the role for anxiety and the stress response. So perhaps CBDA is a far better anti-anxiety cannabinoid, okay? And then CBGA decreases renal fibrosis, which is important, okay? So diabetics, uncontrolled diabetics, they develop retinopathies, They develop peripheral vascular disease. They develop kidney disease, and it's a fibrotic disorder. In this particular model, they used cisplatin, the chemo, to induce kidney fibrosis. And what they found was that CBG significantly decreased fibrosis. And they saw it relative to the control, there was increased mass of the kidneys, which means reduced fibrosis. Okay. And I said some honorable mentions. So the minor cannabinoids, all right. I'm not going to go into detail about them. Again, there are hundreds of them. But one in particular, I do want to talk about THCV. This is one of the most promising cannabinoids in the weight loss space because of its ability to suppress your appetite, improve insulin sensitivity, and it appears to do so in a dose-dependent manner. At low doses, it appears to antagonize or inhibit the CB1 receptor, all right? But at higher doses, it's an agonist. It activates the CB1 receptor. So again, dosing matters. So in summary, with respect to the cannabinoids, each cannabinoid has a host of downstream receptors which determine its cardiac effect. Effects are generally dose dependent, especially in the case of THC that we saw, and it has this hormetic homeopathic response where at high doses, it's toxic and does the opposite of what we wanted to do, but at low doses, it seems to be cardioprotective. Right? CBD, CBG, THCA, CBDA, CBGA, and THCV, they seem to demonstrate the most cardioprotective properties, at least at the studied doses. But they're also likely biphasic as well. We just don't have enough data to show that bell curve. Each cannabinoid appears especially beneficial in improving insulin sensitivity. Each one of them appears to improve insulin sensitivity. Is this dose dependent? Perhaps, but at least through all of the data that I showed or that I looked through, it seems to improve insulin sensitivity, which is what you want. Increasing insulin sensitivity is the opposite of insulin resistance. Okay, if I didn't make that clear. CBD, CBG, CBDA, THCA, CBGA, they appear to have the most potent anti-inflammatory properties. Again, so now we're addressing the inflammatory pathway involved in atherosclerosis, all right? Very important. Now let's talk entourage effect. Now we're getting to it. Now we're going to close into more about my philosophy and how I feel like we should approach medicine overall, but especially with respect to cannabis. So entourage effect implies that it's the combination of cannabinoids, terpenes, and flavonoids, and not the cannabinoids in isolation that have the greatest therapeutic benefit. Okay. And what this study shows, these are different cell lines where they exposed to LPS. So LPS is secreted by bacteria, gram-negative bacteria, and it causes profound inflammation. All right, it's often used in models of inflammation. And so what they did was they cultured these cells, exposed them to LPS. If we look at C here, I'm gonna start here. The blue is the cells that were just exposed to LPS. So we see a huge jump in IL-6, which is a pro-inflammatory cytokine. Okay. When they put LPS and they cultured CBD, we see a modest reduction in IL-6. But if we use the whole extract, we see a significant decrease in IL-6 expression. And that was true across most of these inflammatory markers, all right? Not only in CBD, but also in the THC extracts, all right? In the THC arm, they had two different extracts, okay? But extracts nonetheless, full spectrum, okay? So it appears that full spectrum extracts, have profoundly more anti-inflammatory effects than the individual isolates. Just to hammer the point home again, so this is the last slide. They were cells, in vitro models. This is an in vivo model looking at mice. This is a pain model. So what they found is on the left, CBD isolates in different concentrations. We've got paw thickness. All right. So they did a pain a painful stimulation to the paw, all right? And on the bottom, paw withdrawal threshold. So the higher the threshold, the less painful that mouse is in, the less pain that mouse is in, okay? The smaller the paw thickness, the less of a uh, harmful change to the paw that mouse exhibited, okay? So what we see in increasing doses of CBD is we see this bell curve. Look at it. Let's follow the gray bar, for example. I think that's the most profound. It drops, right, with increasing doses, and then it begins to rise again. So it looks like it's exhibiting that bell curve. Same is true for the paw withdrawal threshold. Okay, at increasing CBD doses, we tend to see this gradual increase, and then it begins to drop. That same bell curve. I'm pretty sure if we went out in doses, we would see a complete bell curve. All right. Whereas with the extracts, we see with each increasing dose, we see a progressive reduction in paw thickness, which is what we want. And with each progressively increasing dose of the extract, we see increasing withdrawal threshold, which is what we want. All right. So the extracts don't have that biphasic response. They seem to have a dose dependent response. And that dose dependent response appears to be of greater magnitude, so a greater analgesic or pain relieving effect than the isolate at the same dose, especially once you get to about 50 milligrams per kilogram. Okay. So all in all, the CBD isolates resulted in biphasic analgesic effect. The the CBD dominant extract resulted in a dose-dependent analgesic effect. And the CBD dominant extract seems to result in greater analgesic response relative to the CBD isolate. And again, when we went greater than 50 milligrams per kg. And lastly, it's just send it home here. So this particular study, they looked at the difference between isolate absorption and full spectrum absorption. And they found that CBD absorption is significantly increased in the presence of THC and or CBG. All right, so we look over here on the left, and this orange solid circle is the CBDA within the extract, and it has a higher absorption relative to the isolate, whereas in the other cannabinoids, the isolate appeared to have higher absorption. Okay, so there was something very special about CBDA, and what they found was that when you administer, or when CBDA is in the presence of THC and or CBG, that the THC and CBG block this intestinal efflux transporter that kicks out CBDA and therefore allows for increased absorption of CBDA. All right. So this is direct proof of the potential synergistic effects of full spectrum extracts. Okay. So now we're getting to the end, and more so about how I approach this from a clinical perspective. Again, and I didn't describe this earlier, but I'm far more of a holistic physician. I'm an allopath by education and training, but I'm a naturopath in spirit. Okay. I take a holistic approach to all my patients, mainly this mind, body, spirit complex. You know, the spiritual element of our existence has really been negated in conventional medicine. And, you know, I look heavily into reintroducing that. The reason why I believe cannabis is such a powerful medicine is because it taps into that spiritual self, you know, that psychoactive effect that we get, that we keep trying to get more and more and more of at higher and higher concentrations, that has therapeutic benefits. Okay, but we have to do it appropriately. We have to, you know, understand. And I think we've lost that understanding, but it is there. Okay. I take a functional approach, meaning I address the root cause of disease. You've heard me talk about this over and over, not symptom management, but addressing the root cause. Because if you can tackle the root of the problem, you can get rid of the problem entirely. You don't have to treat it and manage it, right? And I do this by way of an integrative approach. So I combine conventional and traditional medicine. I think the combination of both allows for a far more comprehensive regimen. Okay. So in doing so, do an extensive risk assessment. All right. That's broken down. I do it into screening and diagnosis. So the screening is a biopsychosocial assessment. All right. We're not just products of our biology, we're products of our environment, of our psychological histories, of our social networks, so on and so forth. All right. So it's important to understand the various elements of our biopsychosocial health. Okay. Doing a history and physical, past medical, all the basic stuff, but really getting into the diet, your physical activity habits, your waste habits. Okay, we don't poop enough as a society. All right, I'm a big promoter of poops, because if you don't optimize the waste systems, then all of that waste backs up. All right. It's like, if anyone who's had a clogged toilet, you had some things in that toilet and it ran over, you don't want that on your floor, on your new bathroom towel. Okay. Same way when you're not excreting your waste from your body, that spills over and desecrates your temple. We don't want that. All right. We want to get the waste out. We want to move our bowels. We want to urinate appropriately. We want to sweat. All right, so waste habits. Sleep, vitally important, critically important. All right, we have terrible sleep habits. Social support. So there's a direct correlation between people who are socially isolated and poor health outcomes. Okay. Stressors, you can't control a stressor, but you can change how you respond to it. All right. And then I do a mood screening. So depression, anxiety, stress, PTSD, you know, do a mini mental. Is this person cognitively intact or do they have signs of dementia? And then physical exam, of course. And with respect to diagnostics, so we're doing a complete metabolic panel, a CBC, checking your thyroid, vitamin D. We're gonna check the fasting glucose, fasting insulin. That's not always routine, but we're gonna check fasting insulin. You'll see why in a second. A1C, lipids. I'm looking at several different inflammatory markers, ESR, CRP, or high sensitivity CRP, AM cortisol, and then HRV, all right, heart rate variability, all right. That's a marker of autonomic function. Okay. Pulse wave velocity is a marker of arterial elasticity. All right. So this is a good marker of who's at greatest risk for suffering a myocardial infarction, a heart attack, or a stroke. All right. And then with respect to the therapeutic approach, so I'm heavy on diet, especially fasting, eating more alkaline. We find an association between acid forming foods, inflammation, and poor health outcomes. So I try to incorporate and promote more alkaline food consumption. Implementing stress mitigation techniques. So low costing or no costing mitigation techniques like diaphragmatic breathing. It costs you nothing to breathe. You just have to be mindful and conscious of how you're breathing. Meditation costs you nothing to meditate. It takes a little bit of practice, but you can get there. Sound healing, big fan of. There have been studies that show that 432 hertz and 528 hertz significantly reduce the sympathetic drive. So it reduces heart rate, reduces blood pressure, reduces cortisol level. And you can put some headphones on, go to YouTube, say, hey, play me 432 hertz, and they'll play it. Okay. Apple Play. And then implement inflammation mitigation strategies. So grounding, I'm a big fan of grounding. If you don't have access to a yard with grass and trees, they sell grounding sheets, grounding pads. All right, these have been documented to decrease inflammation. Light therapy. So I'm a big fan of red and near infrared light therapy. We spend the overwhelming majority of our lives indoors, so we're not getting the sun. All right. We live very unnaturally. We're not getting the sun. We're eating trash. We're eating toxic foods. Okay. All these highly processed, nutrient deficient foods. all right? And then lastly, to consider cannabis therapy. So you see, cannabis is not my go-to all the time. It's part of an entire regimen, all right? As much as I love cannabis, it's not a miracle drug. It's a tool, all right? But I'm addressing the whole person. I'm not addressing a disease. I think that's the biggest flip that I'm trying to impress upon. I don't treat disease, I treat the person. All right. Here we oftentimes we see the person is just the vector for the disease, but no, it's you treat the person. All right. So cannabis is just a tool, one of many tools. Okay. But something to be mindful of is the cannabis drug interactions. All right. CBD in particular is a potent inhibitor of CYP3C19, CYP1A2. All right. And there are a lot of commonly prescribed drugs that are metabolized by these enzymes. Okay. And here's a list on the right. And so if you're on these medications, then it's important for you as a provider and as a patient to know, hey, I'm on these things. Perhaps either I shouldn't consume as much cannabis or maybe lower the dose of the medicine, one of the two, okay? Or increase the dose of the medicine if you're on the THC side, okay? Just briefly, a couple cases, and these are spin-offs of some patients who I've had before. So LT is a 41-year-old male with no significant past medical history. Who presents to establish care. He has no complaints. He denies any current medical or herbal use. He denies any illicit drug use. He's a weekend drinker, sometimes heavy, and an occasional cannabis smoker via vape. He endorses having a family history of diabetes, hypertension. His maternal grandmother and grandfather died from heart failure. He's looking for recommendations to stay healthy. On review of his biopsychosocial assessment, you discover that he has a perceived stress score of 32, which is very high. All right. And he associates that to his job. He's in finance. Okay. He's newly married, eats mostly plant-based and exercises regularly. These are his vitals, heart rate 86. And for those of you who are not in the field, that's normal, anywhere between 60 and 100. Blood pressure 144 over 92 is high. All right, it's a little high. Respiratory rate's 14 and he's breathing 100% on room air. It's great. His labs otherwise are in normal limits. Okay. My recommendation for him, obviously, it seems like stress is the biggest driver of some issues. His blood pressure is elevated. That could be stress related because he eats pretty healthily. He exercises, so this doesn't seem like a sedentary person or he has poor dietary habits. So this seems stress related. Okay. So coaching them about, breathing during the day, at the height of your day when things are stressful, just taking a few minutes, diaphragmatic breathing, maybe put your headphones on while you're doing your reports. When you're home, you're away, if you can fit it into your schedule, fit it into your budget, massage therapy, acupuncture is very good. Loosen up those muscles, all right? Because you hold tension, now you're decreasing blood flow, all right? You're decreasing lymphatic flow. So you're disrupting the flow mechanisms that help to eliminate toxins from the body. Okay, acupuncture, big fan. And with respect to cannabis therapy, sure, yeah, we can initiate cannabis therapy, and I do think it will help in his case. Right, again, if you recall, CBDA seems to be 100 to 1,000 times more potent at the serotonergic receptor. So maybe a tincture or a oral formulation that's high in CBDA. So just the raw flower form, not the decarboxylated form. Okay, keep it in its native form, then it stays a CBDA. Or adding in a little bit of CBG. Okay, CBG appears to lower your heart rate without lower the blood pressure. I'm sorry, without increasing the heart rate. And we can talk about low dose THC because we do see the cardioprotective benefits of low dose THC. He has a family history of heart disease. His maternal grandfather and grandmother both died from heart failure. I don't know the reason. Perhaps it was ischemic cardiomyopathy. That's the highest prevalence. So maybe a low dose THC would be helpful in terms of reducing the risk of developing ischemic disease. All right. And again, big fan of full spectrum. You'll see across the board, I'm always about full spectrum. And that just sticks with my philosophy as as a practitioner, as a naturopath, I think we need our therapy should be as close to its natural form as possible. Yeah, I do think there's a role for isolates, but I'm not the biggest fan of isolates. I'm a far bigger fan of full spectrum. This case here, 67-year-old woman, is obese and non-insulin dependent diabetes. She's not on insulin. Her last known A1C was 7.4, presents to established care again. She has some low back pain. She takes metformin and Januvia, but wants to come off all medications. She wants to go a natural route. But she does report late night snacking. But otherwise, her risk assessment is unremarkable. Her vitals look pretty good. Her A1C, again, is 7.4. Her cholesterol is a little high. And her HOMA IR, which is a marker of insulin resistance, is moderate. All right, it's 2.8. Okay. Moderate is between 2 to 3. High insulin resistance is above 3, and lower than 2 is typically normal. Okay. My recommendations for her, I would definitely want to put her on intermittent fast at 16/8. Alkaline, high fiber, low glycemic index diet. And in terms of cannabis therapy, we can consider it. I would strongly consider it. But I think she would benefit the best if I was able to get her to adhere to a dietary change, and start seeing decreases in her body weight and insulin resistance before initiating cannabis. I think that's when we'll get the greatest benefit. My thought is if you initiate a therapy which increases insulin sensitivity in the midst of having high insulin resistance and therefore high insulin levels, you could actually worsen the problem before you make it better. All right, we see this quite often. And when we do initiate it, I would start her on a THCA, CBDA, maybe some THCV. Again, she has these cravings at night, so maybe the THCA will help with appetite suppression. Consider low dose THC, just given it appears that low dose THC once again helps to reduce formation of atherosclerotic plaques, which she's at risk for. She's obese, she's diabetic. All right. And so it's important that we start on preventative therapies. And then the last patient is the most critical, 58-year-old male, obese, BMI 38, coronary artery disease, has 2 stents. He's on insulin. He's got hypertension. He's got high cholesterol. He presents 1 week post-discharge for a heart attack, which he got a stent for. They found his ejection fraction to be low, 35%. He's on aspirin, Plavix, atorvastatin, carvedilol, Entresto, 20 units of Lantus. Most of his food is fast food because he works 2 jobs and doesn't have the time to cook. His blood pressure is through the roof. His A1C is 11. He's got severe insulin resistance. He's got high cholesterol. For him, it's really about an aggressive lifestyle modification, and this is going to take some coaching, right? It's going to take some time. He didn't just wake up one day and have all these issues. This is a lifetime of poor dietary habits, and some we may not be able to change. This, by virtue, he has to work. He's a 2 job, doesn't have the money, but there's a lot of coaching on ways that we can slowly make changes. With him, I wouldn't initiate cannabis, especially on this visit. Again, I think I would much rather see him adhere to lifestyle modification choices, continue adherence with his current medications, because now we've got significant decreases in his cardiac output, his ventricular function. And so I wouldn't start cannabis therapy in this patient just yet. Eventually, if he seems to do well, he's losing weight, his A1C is dropping, we're coming down off the Lantus, then perhaps we can discuss starting like a THCA with THCV in this patient. I know everyone is going to ask, is most people want to smoke cannabis, whether it's the flower or vaping, most people want to smoke cannabis. And the most popular question I get is, well, is vaping better? And it appears that, and this study was just released actually, November 2024. Okay. They looked at smoking THC dominant flower, vaping THC concentrate, and vaping a CBD concentrate. And they found that smoking and vaping THC was the one that increased the heart rate and blood pressure. And we saw this across the board, okay? Each one is statistically significant before and after vaping, okay? And vaping CBD did not demonstrate increased heart rate or BP, all right? None of these achieved statistical significance. So it appears THC is the driver of this increased cardiac risk, at least in smoking, vaping and smoking. With that being said, I generally do not recommend smoking cannabis in cardiac patients or those at risk. I'm not opposed to people smoking cannabis. I need to make that very clear. I'm not opposed at all. But if we're talking about using cannabis as a medicine to prevent and to manage atherosclerotic cardiovascular disease, I do not recommend smoking or vaping. I need more information. All right. And in summary, very general, cannabis offers an immense potential in the prevention and management of atherosclerotic cardiovascular disease. The paradoxical effects seen in vitro and in vivo warrants further investigation in human subjects. Okay, we're not cells, we're not mice, we're not rats, or at least most of us. And so we need our legislators to get on board, to wake up, to legalize, to federalize cannabis use, to deschedule it preferably, but reschedule at the bare minimum. All right, so that we can start appropriately studying this medicine, because I find it criminal, is evil even to suppress and restrict potentially life-saving medicine, right? So at some point we got to put the people before their profits. Like it's been long enough. It was restricted and prohibited for financial reasons. It had nothing to do with safety. All right. And now we're prolonging its federalization for financial reasons. I'm sure is political, is financial. But it's a medicine, and a lot of people can benefit from this medicine. There's no one size fits all when introducing cannabis as a medicine. All right. This is the beauty and the challenge of this plant. Like I said, it's hundreds of different strains. I can't honestly tell you, okay, yeah, go to this strain will be great for you. We don't have that kind of data yet. I know it's people working on it, but we don't have that kind of data yet. And truthfully, I don't think, and not even I don't think, we have seen you can have two people take the same strain and have two very completely different responses, right? So there's something about the way that plant is speaking to you, right? And this is why I'm a big fan of the Grow program that New York has. So shout out to OCM for and all of our political efforts in legalizing home grow. Because when you grow your own plant, you touch your plant, you sing to your plant sings to you, and it grows to develop the things that you need. You develop this symbiotic relationship. All right, so big fan, and I'm very happy to be in the state of New York where we allow that. That's one of the best aspects of their policy. And lastly, the risk benefit analysis is critical in determining cannabis use. Absolutely correct. I mean, it's true for all medicine, but especially in cannabis because we have such paradoxical effects. Okay. But I do believe that cannabis helps to represent the return of the art of medicine. I think the business of healthcare has destroyed the art of medicine. But I think as we introduce these plant medicines and these various strains, I think now we can really tailor them to the individual. All right, so that's my presentation. And I'm happy to answer any questions, any comments, critiques, and I thank you.
Dr. Hinson, thank you so much. This was so informative, and what a deep dive into cardiovascular health and the effects of cannabis, good and bad. So thank you so much for the presentation today. So we do have time for a question. So this is from one of our audience members, and the question is, what are your largest remaining concerns over potential health risks regarding cannabis and CBD? And what types of studies would you like to see done to address these concerns?
My biggest concern is overdosing. I think that's the biggest gap that we have. Because even our therapeutic approach right now is start low and go slow. That's such an inefficient. It's safe. It's safe. Don't get me wrong, but sometimes you need a high dose. You
Right.
know. And what I showed in the presentation, there's therapeutic benefit at ultra low doses. So we're missing certain therapeutic windows. And right now
Yeah.
we're just
Yeah.
guessing.
I mean,
We're
I
just
agree with
guessing.
you. I think there's so many times we try to figure out, what is a cannabis naive, what is a cannabis experienced patient, and what is their therapeutic dose.
Right.
There really isn't anything because just like you said, I mean, the beauty and the downfall of this plant is that one size does not fit all. So maybe one day we can get some sort of standardization of doses, but right now it just doesn't exist, and it's just really trial and error.
Correct. Correct.
Um, so we had another question. So one of them is my question. I wanted to know, THC increases heart rate and it's dose dependent, right? Is THC, is it possible that over time and over, the body's tolerance of THC, that, blood pressure could normalize? Because would it always cause high TH, high blood pressure? Is it dose and time based?
Yeah, no, yes. So what I didn't show in that slide, I said it was mixed. So with respect to blood pressure, it's mixed data about it increasing. There's data that suggests that it increases blood pressure. There's data that suggests that it decreases blood pressure. In the studies where it shows a decrease, there was a longer duration of use, so it was more chronic. And so, yeah, it appears that maybe chronic use is associated with a reduction in blood pressure, but acute might actually increase it by
Hmm.
way of increasing the heart rate. So it appears that the primary mechanism of THC is more of a beta agonist. All right. In fact, there's evidence that the CB1 receptor and the beta 2 adrenoceptors form a dimer so that when THC binds to CB1, not only does it activate CB1, but it activates the beta receptor. And that's why you get the increased heart rate. But the response that our bodies undergo, because again, our bodies want to maintain a certain pressure always, right? So when the heart rate goes up, when blood flow increases, it causes a reduction in resistance. So you get vasodilation and a decrease in blood pressure. However, if you have any sort of vascular injury, whether from chronic disease like diabetes or hypertension or chronic inflammatory disorder, you cause vascular incompetence. And so that ability to sense the changes in blood flow decreases so that now it no longer vasodilates. So increased blood flow in the same volume causes an increase in blood pressure.
Hmm.
So it's very conditional. It
Yeah.
really depends.
Yeah. Well, this has been again so insightful and so informative. I thank you so much for joining us today to give this wonderful our first inaugural
Yeah,
NY
yeah, yeah.
Cannabis Grand Rounds. Thank you so much.
No, it was
So
my
I just
pleasure.
wanted to just make an announcement that this will be a monthly webinar. And next month, on March 19th, we have Dr. Darrell Wong in honor of kidney Health Month, she will be presenting on cannabis and kidney health. So thank you so much again. And I
Thank
hope
you.
everyone here,
Thank you. Thank you. Thank you.
just soaked in all the knowledge that you provided for us today.
I appreciate that. No, this was definitely an honor.
Thank you.
All right.